Welcome everyone to the 2022 PI Conference. We will be getting started in just a moment. My name is Freetal Mapor. I am the Support Services Program Manager here at IDF. I will be your moderator for this education event. Today, Dr. Jessie Barnum will be presenting on the topic Wiskott-Aldrich syndrome. There will be time for questions at the end of Dr. Barnum's presentation. Please submit all questions that you have to the presenter in the Q&A section of the platform. Dr. Jessie Barnum is a pediatric hematologist oncologist who practices in the Division of Blood and Marrow Transplantation and Cellular Therapies. Dr. Barnum is certified in pediatrics, pediatric hematology, and oncology by the American Board of Pediatrics. She is an assistant professor of pediatrics at the University of Pittsburgh School of Medicine. She received her medical degree from Creighton University School of Medicine, completed her pediatrics residency at Stanford University, her fellowship in pediatric hematology and oncology, blood and marrow transplantation at the University of Minnesota, and a subspecialty fellowship in blood and marrow transplantation and cellular therapies at St. Jude Children's Research Hospital. Dr. Barnum's clinical interests include immunodeficiency, autoimmunity, and immune dysregulation, bone marrow failure, and infections and immune compromised hosts, Welcome, Dr. Barnum. We're so excited to have you here.
Thank you, and thank you for the invitation to speak today. It is my pleasure and honor to be able to speak with you all about Wiskott-Aldrich syndrome. I will be covering some of the basics of the disease and also talk about transplant as a treatment for Wiskott-Aldrich syndrome. Please do feel free to ask any questions you may have in the chat. Oops. Okay, so the history of Wiskott-Aldrich syndrome is quite interesting. You may be surprised to hear that Wiskott-Aldrich syndrome was first recognized not by a subspecialist, but by a general pediatrician. So back in 1937, Dr. Alfred Wiskott, who was a German pediatrician, identified 3 brothers who had eczema, bloody diarrhea, recurrent ear infections, and low platelets. Sadly, all of these boys died at a young age, while in contrast, their sisters were healthy. Then quite a bit of time went by, and in 1954, Dr. Robert Aldrich, an American pediatrician, studied 6 generations of Dutch boys who had similar symptoms to those previously described. And at this point in time, X-linked recessive inheritance was established. And because we hear about X-linked a lot in the setting of, especially with our young patients with immunodeficiencies, I included a slide here just for kind of some information and education. So basically, if you follow this here, males, as many of you know, have 1 X chromosome, and females have 2. So in males who have just 1 X chromosome, mutation in the copy of the gene on a single X chromosome causes the condition of Wiskott-Aldrich syndrome. In females, they must have a mutation on both X chromosomes in order to be affected, which is very, very uncommon. And I believe I have a slide later talking about the rare incidence of female carriers and females that can be kind of affected. So the classic, so basically, if only the father or the mother has the mutated X-linked gene, the daughters are usually not affected and are carriers because one of their X chromosomes has the mutation, but the other one is normal. Sons will then be affected if they inherit the mutated X-linked gene from their mother. Finally, fathers that are affected, they cannot pass X-linked recessive conditions to their sons since they donate a Y chromosome to their sons. So the classic story is that mom is a carrier and she does not know. And that is often how in a lot of these X-linked conditions, particularly in CGD, if you might have already had a talk about this, that's when we can do some testing in the mother, which shows that she also doesn't have normal, for example, NOBA testing, but it's not as severe as someone who is affected. So because I just kind of spent that time talking to you about this, clearly, Wiskott-Aldrich syndrome is a genetic disease. This mutation, while the condition, as you recall from my previous slide, was first described in the late 1930s and then further studied in the mid 1950s, the first mutation was not identified until 1994. At this time, we've had over 160 mutations that have been identified in over 270 families. And there are different mutations that lead to different disease severity, or as we call it, phenotypes of patients that are affected. So my next slide is also just a little bit of background information to just help us further understand what this means. And so, there's multiple different options that we can have. So in most people, they have no mutation, they're unaffected. And this is not necessarily specific for Wiskott-Aldrich. This is really for this concept can be applied to many different genetic diseases. And so we have DNA and then mRNA and then translation to the protein. And so the DNA is read in units of 3, which are called codons. These codons encode for 1 of 21 amino acids. And then basically from there, you can tell that, you have your certain protein that is encoded. Since there are only 21 amino acids, many of these codons call for the same amino acid. And if a mutation calls for the same amino acid, as before the mutation, then it is silent. So basically, as you might see, there is a genetic change in the silent column, but it actually results in the same amino acids. So this would be called a silent mutation. And I just kind of thought this would be useful because you might hear your physicians and medical providers speak about some of these mutations, and they often do manifest differently in how the patient is affected. So usually the mildest mutations are silent. The next significantly affected patients can be nonsense and or missense mutations. And so with nonsense mutations, they basically stop the process of basically encoding the gene, and they stop processing at that point. And so that can affect patients pretty significantly depending on their condition. So when we have this genetic mutation, what happens is we end up with a defective Wiskott-Aldrich syndrome protein. And that is titled WASP. And you may have also heard your doctors talk about this. There's a fair amount of detail on this slide. I don't think, we necessarily have to get into the nitty-gritty, but I just want you to understand that while this is an immunodeficiency, the way in which it causes the immunodeficiency is unique. And so, for example, severe combined immunodeficiency is more typically patients there just have low numbers of T cells, low numbers of B cells. But in patients with WASP, they very well may have normal numbers of T cells and B cells. It is actually the functioning of those cells that is defective. And so that is why it is a little bit harder to diagnose. And so basically what it is the protein is a major regulator of actin polymerization and cytoskeleton reorganization. That leads to an impaired actin-dependent events. And so basically remodeling of the cytoskeleton that's needed to kind of make a gap between the T cells and the cells that are being brought to the immune system to say, hey, this is abnormal. Your immune system needs to do something about it. That is broken. And so the T cells might be there in normal numbers, but they do not function normally. Likewise, there are problems with the cytoskeleton that are critical for cell motility. And this basically, in all these processes that our cells are supposed to do when they see a microbe that they are supposed to attack, they are ineffective in doing those processes, whether it be the adhesion, the locomotion, the homing, and that affects many aspects of our immune system. So just, when we think about all these types of cells in our immune system, T cells, B cells, monocytes, macrophages, dendritic cells, those are some of the most key aspects of our immune system. And so you can see why patients with WASP can be quite affected with immunodeficiency. Now, interestingly enough, even while I feel we have learned a lot about WASP, and it's been a very kind of exciting disease that we've been able to apply to other, just from the standpoint of kind of the understanding that it's helped us lend to better understanding other diseases and then helping to treat them. We are still missing some knowledge in terms of how the defective WASP protein actually lends itself to the development of thrombocytopenia and eczema. So we have some more homework to do in that realm. So all that being said, that's kind of the history, that's the background of kind of what's broken. So now that we've talked about that, with these things being broken, how is the patient affected? How will this affect these little people that we're talking about today? So there's a classic triad with WASP. It's eczema, infections, and bleeding. And so the eczema is an atopic dermatitis. Eczema is a very common condition in general pediatrics. It's one of the most common skin changes you will see in children. But it is notable that patients with Wiskott-Aldrich syndrome do tend to have more significant eczema, specifically eczema that does not respond to just topical steroids and requires systemic therapy, meaning they have to take pills or something to keep it under control. The recurrent infections are quite broad. They're bacterial, they're fungal, they're viral, and I think that's well illustrated by the previous slide that I shared in terms of the immune deficiency with this condition. And then bleeding is due to microthrombocytopenia, which we'll talk a little bit more about. And then these patients also can have autoimmunity and increased risk of cancers. So as you can see from this slide, this is the eczema we're talking about. And in the patients on the left and on the right, it would be fairly moderate. The patient in the middle is very severely affected. And this definitely is something that unfortunately we've seen in our patient population with WASP. The recurrent infections are quite broad. This is by no means encapsulating all of them, but I just included these here as these are fairly common ones that we see. Ear infections, again, a very common thing, but recurrent, difficult to treat ear infections. Patients usually have received tubes to help manage their recurrent infections. Pneumonias, sepsis, meningitis, all of those things are common in patients with WASP. And bleeding. So patients have thrombocytopenia, and it is notable that they have microthrombocytopenia. There are many causes of low platelets, many causes. When we see a patient in clinic that has low platelets, it could be so many things. But there's a measurement that you can do, and some labs will always report it, and other labs, you have to dig for it. But it's called the mean platelet volume. And it's exactly what it sounds like. It's just, how big is the platelet? And in patients that have Wiskott-Aldrich, they have very small, very tiny platelets. And so they should have a low MPV. And as we've talked about before, those platelets are dysfunctional. So not only do they have a low number of platelets, but in stark contrast to a patient with, for example, ITP or immune-mediated thrombocytopenia, with ITP, the platelets are often large. In WASP, the platelets are very small. And so that lends itself to a higher bleeding risk. And that's why we see more things like intracranial hemorrhages. Often the thing that patients present with is because, again, these are boys, is they present with bleeding after circumcision. And they can also present with bloody diarrhea in the first couple months of life. And this is often attributed, classic story that I see is that the patient has a history of, quote, milk protein allergy. It's fairly common in their history, and often that's not the actual cause. Also, patients with WASP can have autoimmunity. The most common flavors of autoimmunity that we see in these patients include vasculitis and hemolytic anemia. Also, patients can have thrombocytopenia, neutropenia, inflammatory bowel disease, arthritis, and nephritis. So lots of inflammation and basically cytopenias. So the white blood cell count can be low, the red blood cell count can be low, and the platelet count is often low. These patients also have an increased risk of cancer, and WASP is actually the first condition in which a predisposition to cancer was postulated to be due to impaired immune surveillance. So our body is able to keep things in check, and there basically when we develop cancer, it's not just a single hit. And so what happens in patients with WASP is they do not have the immune surveillance to help them basically prevent an increased incidence of cancer. So they typically develop leukemias and lymphomas are the types of cancer. Not that they're very common, but if they do get it, those are usually the cancers we see. And WASP is very rare. So it's less than 1 in 100,000 patients. As we've talked about before, the immunodeficiency results in abnormal lymphocytes, particularly in their function, and poor antibody responses to polysaccharide antigens. And so basically a test can be drawn from the blood to determine how the patient responds. So importantly, after hearing all of these terrible things about this disease, it is great to hear about in the late 1960s, as published in Lancet. Actually, the first transplant was conducted in a patient with severe combined immunodeficiency. And soon after that was this successful transplant, which was performed by Dr. Mortimer Borton in Wisconsin. And that basically paved the way. So what I'm going to spend some time talking about now is some of the information that we've gleaned from basically the last 30 plus years now of transplanting patients with Wiskott-Aldrich syndrome. And a lot of this is provided by the research consortium that you probably have heard of, called the Primary Immune Deficiency Treatment Consortium. With that particular group, it has been very helpful to, collect information from centers all across the country and even some internationally, so that we can, often there's papers published that include 5 patients or 10 patients or 20 patients. But when we combine all the patients that have been transplanted with their data submitted to this organization, we can start to get much better numbers. Currently, we're working on a manuscript of over 300 patients who have been transplanted since 1990. So just to give you just a little bit of a preview, this slide talks about some of the different responses that we see in transplant. And what we see here is, there's good follow-up up to 10 years post-transplant. You can see the blue line that HLA-matched related donors have the best outcome. That would be a matched sibling. And so when a patient has WAS and is being considered for a transplant, then we do ask to perform HLA typing of their siblings. For each sibling, there's a 1 in 4 or a 25% likelihood that that person could be a perfect match. And so, you could have one sibling and they could be a match, or you could have 5 siblings and none of them might be a match. It's for each individual case, it's a chance of 1 in 4. So those are typically the patients that have the best outcomes. That being said, there are still, so this is 100% survival, even at 10 years. And you can see the line sort of go down a little bit from there, with the next best outcomes in what's considered a matched unrelated donor. So that is when we go to the National Marrow Donor Program via Be the Match, and we ask for whether we can find a donor that might be matched to our patient. And that is sometimes successful and sometimes not entirely successful, and we can't find a fully matched donor. In that situation, and by the way, this particular slide does include matched and mismatched unrelated donors in that brown line. And so what we do tend to see is that a completely matched unrelated donor it's more successful than a mismatched unrelated donor. Followed by that, you see the outcomes for unrelated cord blood donors, and then HLA mismatched relatives. So HLA mismatched relatives tend to be parents. They tend to be about a half match to the recipient, to the patient with WAS. Now, another thing that is important to note is that, since transplant was started in initially, as we talked about, the late 1960s for Wiskott, but it took quite a while to gather more patients and to, for us to actually capture this data. Excuse me, just one moment. Okay, sorry about that. So what you'll see here is the best outcomes are in kind of the purplish pink color, and that is the most recent era. And so from 2016 to 2020, we have the best outcomes. And really, it kind of falls out almost exactly from the timeline of, with the earlier eras of doing transplant, we've become more successful. Patients have done better. And this is, I think, multifactorial. We've been able to find better matches for patients as we've learned more about how we can get patients a match. Our ability to care for patients, particularly to give them appropriate preventative medicines, especially for infections, to identify infections before they become particularly severe. All of these things have helped us to improve outcomes. All right, so when we looked at some of these patients that presented and had autoimmunity prior to transplant, for a cohort that we evaluated with just under 130 patients, 25 of them had autoimmunity when they presented for transplant. And then we followed them over time. And at 100 days, 18 of the 25 had resolution of their autoimmunity. When we followed them further to 1 year post-transplant, 23 out of 25 had resolution. And we also studied the patients because, independent of having WASP, patients after transplant can develop autoimmune conditions. They tend to be, again, the cytopenias, so temporary drops in white blood cell, red blood cell, or platelet counts. And so we also studied that, and 14% of the patients developed de novo autoimmunity. So this is a fairly involved, complex slide, but I think, I just wanted to give you a little bit of a flavor of kind of some of our goals and some of the things we're evaluating when we look at patients after transplant. And for those of you who have, children or people that that inspires you to be on this call today, you probably have heard your providers talk about chimerism, conditioning intensity, all of those things. So it's RIC versus MAC. And what that means is reduced intensity conditioning versus myeloablative conditioning. Myeloablative conditioning, classically, what it means is that if you give a patient chemotherapy and or radiation for transplant, and then you do not give them stem cells after that, their stem cells will not recover. They will become what's called aplastic, and they will not have any blood cells. If we give someone reduced intensity conditioning, classically what that means is, in contrast, after the chemotherapy and or radiation, the patients will recover blood counts, and they will be their blood counts typically. So this is just a little bit of more information about kind of what we're looking at after transplant. So you see the bar graphs show you RIC versus MAC. And then it's not super important for this, but basically the top column is CD3 or T cell chimerism. The middle column is CD19 B cell chimerism. And the bottom is myeloid chimerism. And so big strokes are that majority of the patients were full donor, and we characterize full donor is greater than 95% donor cells. There was a low incidence of graft rejection. Contrary to maybe some previous teachings, less than 5% of this patient population had graft rejection, as in less than 5% donor cells. Now, still, there were some additional patients that underwent a second transplant or a boost. And a boost just means that they got additional stem cells from their donor. So some of those patients were in the mixed chimerism group that were actually affected to the point that their platelet count was low enough, that they had some sort of persistent disease findings that made them good candidates to have another transplant. And so overall, there was a higher percentage of patients that had full donor chimerism when we were giving the myeloablative conditioning, or the MAC. And chimerism, just to sort of make sure, for those of you who may not have heard of that, it's the measurement of the percentage of donor cells versus the percentage of recipient cells. And so when we talk about full donor chimerism, that is, greater than 95% of donor cells present. When we talk about basically rejection, that's less than 5% donor cells. And everything in between is some degree of mixed chimerism. Again, kind of a fairly involved graph, but what we're looking at here is basically we want to see and follow these patients over time to see how they do. And so recovery of platelet counts correlated with the degree of donor myeloid chimerism. So for patients with Wiskott-Aldrich syndrome in particular, you can look at what's called whole blood chimerism, or you can look at chimerism in different subsets of the immune system. And so when you look at myeloid chimerism, that we have noted is the most important for patients that have Wiskott-Aldrich syndrome. And so platelet counts for patients with low-level mixed chimerism, as in 5 to 49%, remained inferior to those who attain full or greater than 95% donor myeloid engraftment. Now, in this next phase of analysis that we are currently doing, we are breaking these groups into smaller cohorts. So instead of taking 5 to 49%, we have smaller groups, just so that we can try to get a better sense of, what is the percent donor chimerism that we need to see the clinical outcomes that are most important. Because at the end of the day, if you're 90% or 80%, but if clinically you have no signs or symptoms of disease, then the number is a little bit, it's not really significant. And so tying with the last slide, in looking at the reduced versus myeloablative conditioning, we also really want to know with more patients if we can see that which one of these is better for patients, which, do we need to do the myeloablative to try to get patients better donor chimerism and better platelet counts? Or can we get by with doing reduced intensity conditioning? And in those situations, we expect that patients should have less acute toxicities of transplant, as well as less late complications or late effects. And as we're transplanting these kids, looking at our cohort, I think it's 65 or 70% of our patients that have been transplanted over the past 30 years or so are less than 2. So patients are very fragile at this young age. And so we want to do, we don't want to do too much if we can get by, with letting them have less risk in the acute phase in the first, 100 days post-transplant, but also in the long term, because they are so young and they have so much life left to live. So again, I promised you that I mentioned this. So basically symptomatic carriers can be seen. And so it's rare though. So there's times, again, we don't have to get into it too much, but with the 2 X chromosomes, you usually have one kind of protected. But if you have what's called unbalanced X chromosome inactivation, then you can actually see patients be symptomatic, but it's very rare. So I know we need to have some time for open discussion, and I would be more than happy to answer any questions that you have.
Thank you, Dr. Barnum, for sharing that wonderful information on WASP for the idea of community. And as you said, we now have time for Q&A. For our audience, just a reminder, please remember that everyone's treatment and condition is unique. The information presented during the session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with questions concerning a medical condition. At the moment, I don't see any questions in our Q&A platform, in our box. So we'll go ahead and we'll give a couple more minutes and see if anyone has any questions. Okay, we have a question in. What medications are used for reduced intensity conditioning?
Okay, so there's a variety of medications that can be used in reduced intensity. And so it also has to do with not necessarily just the medication that's being given, but also the dose. Okay, so for example, busulfan and cyclophosphamide combined, if the busulfan is higher dose, would be considered myeloablative conditioning. But if the dose of busulfan is low enough, it can be considered reduced intensity. Some of the more common reduced intensity conditioning regimens that I've seen are busulfan combined with fludarabine, thiotepa and fludarabine, plus or minus Campath is another example. So it's kind of basically when it comes to transplant, it's kind of like a recipe. And so it just depends how many different agents you're including and at what doses.
Okay, thank you for that answer.
Mhm.
Next question. When would you administer IVIG to a patient?
Great question. So I would, first of all, recommend that if you have a patient with Wiskott-Aldrich syndrome and that there's any concern about their IgG levels or something like that, that you have them seen by an immunologist. I think they are key members, especially prior to the patient coming to transplant, that they should have an immunologist part of their care team. But in general, it's a patient who has low IgG levels and or has recurrent infections.
Awesome. Thank you for that.
Mhm.
And the last question we have in here is, would you please comment on gene therapy as an option and also whether BMT is recommended for all patients?
Okay. So, so I personally have not done gene therapy for Wiskott-Aldrich syndrome. It certainly has been done, and that has been primarily in Europe. I think, it was actually quite a while ago now. And honestly, I'm surprised it hasn't taken off more than it has. But I think that is partially because it is challenging. And what can happen with gene therapy is there may be a nice response initially, but you can lose the gene markers over time.
Mhm.
And so then you're kind of left in a situation of having still persistent disease. And so I think it's worth continuing to monitor, and gene therapy overall is improving in so many ways for so many conditions. And I do think Wiskott will become more accessible. Second question is, should every patient with Wiskott-Aldrich get a transplant? So, we do, I didn't necessarily go through this, but we do assess patients for severity of Wiskott as well. And we do that with what's called a WASP score. So for patients that are more severe, and we basically grade their, all the things I spoke about. So their history of infections, systemic therapy for eczema and things like that. For patients who have a severe WASP score, absolutely, I do think they should get a transplant. As far as patients that are very mild, there is also a condition that's called X-linked thrombocytopenia, XLT. You may have heard about that. It's an extremely mild phenotype, and some patients can do well without transplant. But I think I would say it's an individual case-based discussion in terms of the severity of symptoms and also other aspects of the patient. Do they have other risk factors for going through transplant? Are they otherwise healthy?
Okay. Thank you for that. We do have one more question.
Mm-hmm.
What functional tests are used to evaluate recovery of a patient after BMT?
Yeah. So there are a number of things that we look at. So probably the easiest and most significant one is, what is the platelet count? What is the mean platelet volume? And those are helpful things to follow. In addition, once the patient is far enough out from transplant that we can start the revaccination process. Many of you probably know that after bone marrow transplant or stem cell transplant, we have to revaccinate against all all things that children were vaccinated against as a baby, with the exception of rotavirus. And so it's actually very key to look at how patients are responding to their vaccinations. And so that's something I look at. I also look at response to polysaccharide antigens. And so titers to, you might have heard people talk about titers to vaccines are helpful. Also just assessing their T and B cell subsets in lymphocyte subsets is what we call it at our institution. And then I would also say it's helpful to look at recent thymic emigrants to look at the functioning of the thymus. And of course, all of these things in conjunction with the clinical picture of a patient that is hopefully no longer having recurrent infections and not having severe infections.
Okay, thank you.
Mm-hmm.
We have one more question. I am going to go ahead and ask this. The question is, how can I tell if my son is cured after BMT? How long do we have to wait to know?
Yeah. So that's such a tough word, cure. In the pediatric oncology world, we have certain timeframes that we say, that if you've been cancer-free for this many years, you're considered cured. To my knowledge, we don't necessarily have hard and fast timeline for when you would be considered cured. And I think that is important just to note that patients that have had a transplant, they're just going to need long-term follow-up. Following the chimerism every year is very helpful. So with patients with Wiskott, getting chimerism and checking their blood counts are honestly the two most key things, and then also just how they're doing clinically. In general, when I see patients that have maintained good donor chimerism and good platelet counts for 2 to 3 years post-transplant, that's usually indicating that they're doing well long-term. Mm-hmm. But and I haven't seen this, but I'm in a lot of groups with people that take care of, just many of these patients around the country. And I have heard of these, unfortunate stories of someone who is 8 or 9 or 10 years out from transplant who started losing donor cells. But it's really not common. So try not to really lose sleep and perseverate over that. This is very, very rare. But I think it's just, it just for me reiterates the fact that having annual follow-up for your child is very important.
Thank you so much. We have one more question, a few more questions than I anticipated. Our question here is, I may have missed this in the beginning. Is there screening, like a newborn screening test that can help determine if someone has WASP?
No, there is not. I wish there was.
Okay. One more question. I've heard my son can have infidelity. I'm sorry, not infidelity. Whoa, excuse me.
Infertility?
And excuse me, sorry, this is, sorry, here we go, one more. Sorry about that. I've heard that my son can have infertility after transplant. When can we check to see if this is true?
Yeah, great question. So it can happen. And this is, again, one of the reasons we're trying to study how intense the conditioning chemotherapy needs to be, because generally the more intense the chemo, the higher the likelihood of infertility. But nothing is absolute. So even if you got myeloablative chemo, I've seen plenty of those people also go on to have kids. So you have to wait until the young man is of age where basically he can provide a sample to be tested. So I would just, kind of have the conversation, after puberty and at a point where you're comfortable talking to the child about it. But basically it can be tested and that can give you some information. And usually that's quite helpful. But I would also recommend, depending on the age of the person you're talking about, if you're really, if they're wanting to have kids soon, that they see a reproductive endocrinologist, just to help them guide. And then also just to kind of talk about the whole process for them.
Okay.
And also, sorry, one thing I also want to make sure to say is just genetic counseling, so that they can kind of understand what things will look like. Like if they have a boy, they won't even carry it. But if they have a girl, half of their girls will carry it. And just so they can be informed about that before they plan to have children.
Thank you. Another question, my son has mild WASP. How can I decide if he needs a transplant?
So I think, kind of what you said at the beginning of this section, it's really hard for me to just from that very short statement say too much.
Yeah.
I think, it's just very key to talk with your doctor and your medical providers about it. There are some patients that have very mild disease, or look like they should have mild disease. They end up having more issues than we anticipate. And one thing I do want to focus on as well is that it does make a difference when we perform transplant for patients with WAS. In general, for transplant, the younger you are, the better you do. But with WAS, we know that patients that have had more bleeding episodes, more infections, they have more issues, they don't do as well. And so in particular, being less than 5, we found in our last study to be pretty significant in terms of how they do. And I believe it was on the order of, high 90s in terms of survival if you're less than 5, whereas it's quite a bit lower if you're older than 5.
Perfect. Thank you so much, Dr. Barnum. Our time has come to an end. We really appreciate you, and it's been such an honor to have you with us today. For those who are interested in learning more about WASP, please visit the WASP Foundation's booth in the virtual exhibit hall. Enjoy the rest of your conference, everyone. Thank you so much for joining. And again, Dr. Barnum, thank you so much for this wonderful presentation.
Thank you.